Now, the principles of single fraction radiosurgery have been well known since the initial phase 1 dose-finding study. And essentially, as the maximum tumor diameter increases from less than 2 centimeters, 2 to 3, 3 to 4, we dose de-escalate as a result of the increased volume. And you could say, well, that's paradoxical to what we should be doing, because as the tumor cells increase, we need to try and control them more. But the limiting factor, as Veronica noted, is radiation necrosis, and that really is becoming the bane of our existence as radiosurgery practitioners. So this has been the paradigm for years, and what is the result of this paradigm? Well, even early data many years ago from the Cleveland Clinic showed that as you reduce from 24 gray to 18 gray to 15 gray, as a result of the tumor diameter, you reduce your chance of local control. And they concluded that for tumors larger than 2 centimeters, they're less effectively controlled than smaller lesions because you're dose de-escalating. Now, what is the impact in terms of adverse radiation effect, including radiation necrosis? Well, that also similarly is congruent with the diameter of the maximum tumor that you're treating. And this is a very eloquent study more recently by the UCSF showing the stepwise increase in the probability of adverse radiation effect as tumor diameter increases. So what happens if you take a 4 centimeter, 5 centimeter, or in this case 14 centimeter cube volume metastases treated with radiosurgery and still dose de-escalate? So these tumors were treated with a median marginal dose of 14 gray, and they observed unacceptable radiation-related toxicities of grade 3, 4, 5. And just shows you that even though you're dose de-escalating, you're significantly increasing the risk of serious adverse effects that could harm patients. So in this patient that was referred to me had whole brain radiation because this tumor was deemed to be too large for radiosurgery. Well, whole brain radiation is not going to control this metastases. And lo and behold, 6 months later, the tumor grew. Now, this person, if they were an uncontrolled extracranial disease, poor performance status, they may have died before the tumor actually grew with the whole brain radiation. But this patient was very good, breast cancer, sole lesion, and unfortunately was treated with whole brain radiation alone. So at this point, I treated the patient with hypofractionated radiosurgery. And this is a strategy to overcome the dose de-escalation limitation. Hypofractionated, and I use 5 fractions. I gave in this situation 35 gray and 5 fractions. We typically use about 30 to 32.5 now, and had a beautiful response for several years. And some of our early data have been published in abstract form using a linear accelerator showing good rates of local control with a 1-year local control rate of 80% and an acceptable symptomatic radiation necrosis rate. And these are, again, larger tumors that would have had a low rate of local control and a high rate of adverse radiation effect. So why fractionate? Well, the pros are that it's safer on the normal tissues due to normal non-tumor tissue repair in between fractions. There's technical safety as fractionation blurs dosimetric uncertainties. And what we mean by this, from fraction to fraction, the hotspot is never in the same area. And there is some variation that happens in the dosimetry to allow for a safer overall profile. It may be more effective due to reoxygenation and redistribution between fractions. And you can safely escalate the total dose to achieve an equivalent dose in 2 gray fractions of, say, 20 gray in 1 by giving, say, 29 gray in 3 fractions, or between 30 to 35 gray in 5 fractions. The cons may be tumor repopulation and tumor DNA repair between fractions. Now, this is more of a situation when we're dealing 6 to 7 weeks of radiation, not a week of radiation. There may be changes in tumor dimensions between fractions. That certainly can be the case, and with new MR-based technologies, we may be able to visualize this each day between fractions. And we may not be maximizing some of the new biologic effects inherent to very high-dose single-fraction radiosurgery, but again, the jury is out on this, and we're learning more and more in terms of the radiobiology. So what are some of the data? Well, Minetti was one of the first ones that looked at their multi-fraction radiosurgery using 3-fraction approach versus single-fraction radiosurgery for tumors greater than 2 centimeters in maximum diameter. And what they showed was better local control, less radiation necrosis. So the principles in terms of radiobiology have played out here in clinical data. Now, Do we have a phase 1 dose-finding study like we did back then by Ed Shaw? Well, we do now by the Korean group for the 3-fraction approach. And what they showed was that the local progression-free survival rate was relatively equivalent when you're talking about 10 grade times 3 or 9 grade times 3, but it reduced with 8 grade times 3. So there is a local control relationship within the hypofractionated regimen. And they showed, however, the adverse radiation effect can be dramatically increased again if you go too high. And this is the 10 grade times 3 curve versus the 9 grade times 3 curve. So certainly in de novo metastases that we treat with 3 fractions, we use the 27 grade times 3. Now what about cavity radiation? This is another area where I routinely treat with single fraction radiosurgery. I never give single fraction radiosurgery for surgical beds. And why is that? Well, surgical cavities tend to be large and have irregular borders. And this is why hypofractionation allows for increased flexibility for irregular targets in terms of shaping the dose distribution. It allows for some margin beyond the surgical cavity to take a meningeal margin. So we do chase out the surgical bed with typically a 5 millimeter margin along the meningeal margin. It may be safer as essentially the target is that rim of normal tissue, and again, we're dealing with the issue of radiation necrosis down the road, and again, we can increase the total dose by hypofractionating as opposed to dose de-escalating with single fraction radiosurgery. So what are some of the data? Well, these are data that we published in Neurosurgery looking at our experience. Here's a typical case of a posterior fossa metastases treated with surgery, followed by postoperative cavity hypofractionated radiosurgery, and a beautiful response. Now, our data show a cavity 1-year local control rate of 84%, and again, a very acceptable symptomatic radiation necrosis rate. This is again with 5-fraction approach. Now, what does it look like with single fraction radiosurgery? Well, we have 2 major randomized studies being done, one that compared cavity radiosurgery to whole brain radiation, and then the MD Anderson group that actually looked at surgery alone versus cavity radiosurgery. Now, from the radiosurgery versus whole brain data, we were actually quite alarmed at the fact that the local control rate at 1 year was 60% as opposed to 80% with whole brain radiation. Now, when you look at the data from the surgery versus cavity radiosurgery trial, we see that you get good control rates with small cavities, but it really becomes suboptimal for the larger surgical cavities, and this is based on the preoperative diameter. So there were poor rates of local control with surgical bed single fraction radiosurgery, and we certainly didn't see this in our experience. So what are some of the other areas where we would use fractionated stereotactic radiosurgery? Well, one of the interesting areas is in when we deal with repeat radiosurgery. So this small lesion in melanoma was treated with 16 gray in a single fraction, and lo and behold, we had progression about 1.5 years later. At this point, we were confident that this was tumor progression, not radiation necrosis. Now, if I re-irradiated this with single fraction radiosurgery, my radiation necrosis rate would be about 20%. So as an effort to reduce the risk of radiation necrosis, improve rates of local control, I gave this hypofractionated radiosurgery. And with these small tumor volumes, we use certainly the gamma knife icon, so we can use no margin in terms of PTV and target with the same principles of radiosurgery with the gamma knife. Now, what are the data in terms of radiosurgery for repeat radiosurgery? Well, again, for the UCSF group, they show actually one of the most important predictors of ARE is giving a second round of single fraction radiosurgery. And this is reasonably consistent in the literature with about a 20% risk of adverse radiation effect. And for us, that was unacceptable, and we re-irradiate with hypofractionated radiosurgery. There are some data, these are some data from Japan that actually showed that not only in theory the adverse radiation effect profile will be better, but actually the local control rate would be better. And local failure rates were better with SRT versus repeat radiosurgery when we were dealing with radiosurgery failures. Again, limited data, but some good data in terms of food for thought. Now, what are some other types of hypofractionated radiosurgery? It's not just daily 3-fraction or 5-fraction. In some cases, we used what we call staged radiosurgery. So this is a patient who had surgery for this metastases, was treated with hypofractionated radiosurgery with 25 gray in 5 fractions in the cavity at an outside institution. About a year later, there was clear recurrence. Now, in this situation, we weren't burdened by the rush of trying to get chemotherapy in very quickly. This person had controlled disease. So here I said, well, why don't we do the staged approach? So we give a first fraction of 8 gray, then 2 weeks later we re-image. Hopefully there's some tumor reduction, and we can reduce the volume that we re-irradiate with for the second fraction, and I give a second 8 gray. And then 2 weeks later, it's even smaller, I re-image, replan, and here I give 4 gray in my third fraction because I'm re-irradiating. So in total, this is 20 gray in 3 fractions, and lo and behold, the patient has done very well for some time, especially in an eloquent location. And this idea of a gap and a hypofractionation, dose reduction in volume by staging it and trying to reduce the volume irradiated can borne out to have significantly improved outcomes. Now, the last kind of example I want to give you is this area of cavity reirradiation, because this is more and more as patients live longer, we're going to have to deal with this as well. So this is patients with a cavity large metastases, treated with hypofractionated radiation in 2016, 30 gray in 5 fractions, had a good response, but lo and behold, started having changes. Now, is this adverse radiation effect or not? We employed surgery. We proved that this was actually tumor recurrence, and then I re-irradiated. Now, here the principle is I used another 5 fractions. If I'm not going to increase the number of fractions, I dose reduce the total dose. So I gave 25 gray in 5 fractions, and now we're here in 2020. Sure, there's adverse radiation effect. The patient's asymptomatic, but the patient is still under control. And this area of understanding the imaging that happens in the long term is one that we're still a source of research and understanding. So I'd say in conclusion, technology has evolved from frame-based single-fraction radiosurgery. Hypofractionation in selected patients has the potential to improve local control safely. No longer is radiosurgery a one-size-fits-all treatment, and randomizer trials are underway to provide level 1 evidence, but we are in the field of understanding this technology more, and more we do realize this is an increasing standard of care, in particular for larger metastases. And with that, I say thank you very much.